4, 3, 2, 1. You're live.
Good evening, ladies and gentlemen. Welcome to the monthly academic initiative of the Asia Pacific Trauma Society. Going through this global pandemic, the Asia Pacific Orthopaedic Association and the Trauma Society is committed to its goal at spreading education across our region. Today, we have a heart-burning topic on the management of pelvic acetabular injuries and a star-studded, internationally acclaimed faculty. Without much ado, I will first introduce you to the speakers and then proceed with the presentations. Our first presentation will be on the management of pelvic injuries. The speaker is Dr. Wael Taha, who is a consultant in the Prince Mohammed Abdul Aziz University in Medina, Saudi Arabia. He is the chair of the AO Trauma Education Commission and the vice president of the Asia Pacific Trauma Society. Over to Dr. Wael Taha for his first presentation.
Thank you very much. Can you see my slides?
Yes, sir.
Thank you very much. It's my pleasure to be with you here. And this first topic is going to be on the management of pelvic fractures. And I will touch more on definitive fixation. This is a very big subject. And what I thought I would do is that I will talk about some controversial issues in the management of pelvic fractures. We will talk a little bit about the packing versus the use of angio and embolization, which one is preferred over the other, if there is one that is preferred over the other. Another point that we will talk about will be when to fix the posterior lesions or the posterior pelvis in an anteroposterior compression fracture type 2. The third point I will touch on is the lateral compression fractures. Are they really stable? And then on the vertical shear fractures, where do we start the fixation? We obviously know that these need to be fixed, but where do we start the fixation? Do you start posterior or do you start anteriorly? And when you have a combined injuries that involve the pelvis as well as the acetabulum, which one do you fix first? So on the first point or the first topic, packing versus the use of angiograms and immobilization. We know whenever you have a patient who's hemodynamically unstable, we start by managing the hemodynamic situation following the ATLS protocols. And when it comes to the pelvic fracture, we have two types of procedures. One of them are non-invasives and the others are invasive procedures to try and control the bleeding from the pelvis. The non-invasive measures include the use of things like the circumferential sheets, pelvic binders, internal rotation of the legs, sometimes applying traction, and in specific situations, the use of a military anti-shock garment. Invasive measures include the use of external fixators, pelvic clamps, acute fixation of the fractures, the use of angio, and pelvic packing. So when it comes to pelvic angiography and immobilization, these are very specific for arterial injuries, which in all pelvic fractures account for about less than 3% of all injuries. However, when we talk about unstable fractures, the rate has been shown to be as high in some series as 80%. The use of angiography can be diagnostic as well as therapeutic. However, it's not a time-friendly procedure because you do need to transfer the patient to the angio suite to get this done. You need to call the people to come and do this. So it is a time-consuming procedure. You're also not able to do any simultaneous management of the patient while he's having the angio performed. It needs a skilled radiologist, and the embolization itself is very effective if you do have a skilled radiologist doing this for you. And the problem is that this is not available everywhere. The the use of a CT can sometimes help predict who needs an angiography. If on the CT scan you could see that there is a hematoma and there is extravasation of the dye, this most probably means that there is an arterial bleeding, and this following this has a sensitivity of up to 90%. And so doing this, like looking at the CT and looking for extravasation of the dye and using that as a way of predicting the need for an angiography is a very acceptable way of doing so. Now, coming to pelvic packing, this has to be done in conjunction with some kind of applying a fixation to the pelvis. If you pack the pelvis without fixing the pelvis, you will just expand the volume inside and you will not be able to control. So there has to be something to stabilize the pelvis. So the use of an external fixator or C-clamp must be applied first, and then you do the packing. The problem with the packing is that it has to be taken out in about 48 to 72 hours, and there are some complications associated with this. However, the biggest advantage is that while the general surgeon or the trauma surgeon is doing a procedure on the abdomen, this is possible. This can be done simultaneously at the same time. Now, choosing which one to go, there are two different systems. One of them is mainly the German system or the European system, where you have a comprehensive trauma surgeon, a surgeon that does everything. He can deal with the abdominal and the trunk injuries as well as with the musculoskeletal injuries. So these usually they tend to do the fixation earlier. And they would manage a hematoma in the pelvis with packing. Now, the other system, which is the North American system, the resuscitation is usually done by a general surgeon. And so in these situations, they usually tend to use and be more liberal on using arterial angiography and immobilization. However, if we look at both, each one has its advantages and disadvantages. The use of angio is a less invasive compared to pelvic packing. It can be very highly successful if the bleeding is coming from an artery. However, as we said before, it's time consuming. It requires an intervention radiologist, and the patient has to be relatively stable. You cannot take him to the angio suite while he's unstable. However, with pelvic packing, it's done quickly. It's part of the laparotomy that the trauma surgeon would do. It doesn't require any special technology, and it can help actually stabilize the patient later on for an angio if that is needed. The disadvantage is that it is invasive. There is a risk of infection, and the packs need to be removed at some stage, about 2 to 3 days later. In cases where the hemodynamic stability can be achieved with volume resuscitation and the patient becomes stable, then an angiography could be considered. This is a study that was published in 2009, and it looked at the outcome for retroperitoneal pelvic packing compared to the use of pelvic angiography. And when we look at the time to intervention, it was definitely the packing was quicker, going for a packing, as well as the use of blood transfusion was less with the packing group. However, the mortality rates did not show much of a difference. So the next point I will touch on is when to fix a posterior pelvic fracture in an anterior posterior compression. Now, we have different types of anterior posterior compressions. There's the type 1, where there is a diastasis at the symphysis, but because the posterior ligaments and the floor ligaments are intact, we don't see a lot of displacement in the symphysis. In the type 2, there is rupture of the anterior sacroiliac ligaments as well as the floor ligaments. So there is more diastasis in the symphysis. And in a type 3, there is complete disruption of the posterior ligaments. So the whole hemipelvis is very unstable. In general, type 2 APCs require surgical stabilization. There has been no study to compare surgery to non-surgical management of these injuries. However, long-term follow-ups have shown very good outcomes in surgically fixed ABC2 fractures. However, the question remains, when do you fix the posterior elements in these types of fractures? Do you always need to fix them, or are there a subtype of fractures that do not need posterior fixation? And so this article that was published in the JOT in 2011 looked at this by doing an examination under anesthesia. So if you have a patient with an ABC fracture, especially if it's a type 1 or a type 2, and you're not sure if this needs posterior fixation or not, doing an examination under anesthesia will be very helpful. If there is no widening in the symphysis beyond the 2.5 centimeter that we usually see, or the 5 centimeter that we usually see in these cases, then that means most probably that the posterior ligaments are intact and only anterior fixation in these situations will be needed. However, if the symphysis on stressing does increase in size, then this means that at least the anterior part of the sacroiliac ligaments are involved, and in these situations, you would need to go for a posterior fixation to supplement the anterior fixation. Doing this has been shown to have better outcomes, and the patients usually have less back pain on long-term follow-up. The third point I would like to touch on is the lateral compression fracture, and when do we fix them? We've got the three types of lateral compression fracture. In type 1, there is mainly a fracture or in the pubic rami. These usually are comminuted fractures and they displace internally. In a type 2, there may be a severe posterior lesion. And in a type 3, this is what is known as the bucket handle injury, where you have an internal rotation injury on one side and an external rotation injury on the other side. Where the type 3 is treated surgically, there is a little bit of controversy regarding the type 1 and when do we label it as a type 2. And so again, the idea of doing an examination under anesthesia becomes very helpful in these cases, especially if the patient is having problems mobilizing out of bed and they have a lot of pain. In these situations, you may opt to do an examination under anesthesia and specifically do a push-pull test. Now, if doing this does not illustrate any sagittal displacement in the posterior pelvis, then the patient can be treated conservatively. However, if there is, with the push-pull test, there is sagittal displacement of more than 1 centimeter, then surgical fixation becomes indicated in these cases. Another variety of the lateral compression fracture is what is called the tilt fracture, where you have a fracture of the superior pubic rami, where it rotates and displaces and goes through the symphysis pubis, and this pushes inferiorly, and especially in females, this may cause pain during intercourse, and so in these situations, surgical correction of this lesion would be strongly advised. Now, the fourth point I would like to talk about is the vertical shear fractures, and the question is, which side do we start with? Do we start with the anterior fixation or with the posterior fixation? I always, when I ask my residents this, they said we start posteriorly because that is what's written in the textbooks. However, let's look at this. This is an injury that involves the anterior pelvis as well as the posterior pelvis, and there is a superior displacement. Now, in order to fix this, you need to reduce this pelvis before you proceed with your fixation. Now, the fixation anteriorly can be anything like a plate, the use of pubic rami screws, an external fixator, or some have described the use of something called a subcutaneous fixator. Posteriorly, you could use sacroiliac screws, anterior plating, or tension band plating. Whatever you need to do, you need to reduce the pelvis before you start. And so the question is, which lesion do you start first? Now, remember, these are very severe injuries. There has been extreme forces that cause these deformities. Timing and accuracy of reduction have a very important role to play in the prognosis. If you delay these more, the reduction becomes even more difficult. Performing an anterior fixation at the beginning helps neutralize many of the forces that cause the deformity and will make the reduction of the posterior elements a bit easier. And so when you have a situation like this, doing an anterior fixing the anterior ring first would help reduce the posterior elements. Of course, you wouldn't have something like this, but you would have at least the vertical displacement reduced to an extent that would make it easier to proceed with the posterior fixation. Especially if you want to put in sacroiliac screws, you need to have the posterior hemipelvis reduced well before you put the screws in. And this brings us to the topic of the sacroiliac screws. And I thought I will touch on some tips on how to make that easier for everyone. So to be successful with sacroiliac screws, you need to make sure that you have got a proper reduction. Use a radiolucent table. Partially threaded screws will help compress the fracture. You could use fully threaded screws to augment the fixation after you've put in your partially threaded screws, provided you're using partially threaded screws, provided you don't have a fracture through the foramen. The washers help avoid penetration of the screws into the iliac bone, and the screw direction is usually dictated by the fracture configuration. When you start, you need to have these 4 images: an AP, an inlet, outlet, and a lateral X-ray of S1. These are the kind of X-rays that you want to have. You want to clearly see the foramen of S1 on the outlet views and clearly see the anterior border of S1 as one line on the inlet projection. Having a clear lateral X-ray is also very important. I use this to mark on the side of the patient the area of S1. So now I know that this is the area of S1. This is the superior border of S1, and this is the anterior border of S1. And this also will help with using the CM, and which I will illustrate in a minute. And also you have to take care of this alar indentation, which is which tells us where the L5 nerve root runs. So you need to be below this line here to make sure that you do not cause an injury of the L5 nerve root. Now, these lines also help you with the CR. Many times when you're putting the screws in or the wire in, and the wire is anterior or posterior, these lines can help you guide you how to move your arm, your wire in relation to the X-ray. So if you're doing like this is an inlet view. So you're looking at moving your screw anterior or posterior. So as you could see, this is the line of your movement. When you're doing the outlet view, this is the line where you'll be moving inferior or superior. Once the screw is put in, you need to do a lateral X-ray again to make sure that you're below the alar indentation. Tension band plating. This is one of the methods that could be used, especially if there are some contraindications using sacroiliac screw, or if there is not enough expertise in using this. This was described by Mata, and you use a 4.5 reconstruction plate with 14 holes. You bend it. You make 2 incisions on the just lateral to the posterior superior iliac spine, and you pass the plate after bending it into a U shape under the skin, and you fix the plate with 2 screws into the iliac bone. This is a case with bilateral DNE type 2 fractures going through the foramen, and it was fixed with this type of fracture. And because of the shape of the plate, it helps close the pelvis. So sometimes you could get away with not doing an anterior fixation. Tension band plating, as I said, may be very helpful if you have DNE type 2 fractures, or if there is sacral dysmorphism, or if there is lack of expertise in doing sacroiliac screws. However, you need to make sure that you take good care of the skin, and the closure of the wound has to be done meticulously to avoid complications with the skin. The last point I would like to talk about is the combined injuries, pelvic and acetabular fractures, and which one do you fix first? The most important we know is the anatomical reduction of the acetabulum in order to prevent further complications in the hip joint in the future. But in order to fix the acetabulum well, you need to reconstruct the pelvis well, so that you could reconstruct the columns of the acetabulum. One of the issues in these situations is that you cannot use the lower limbs to help you with the reduction of the pelvis if you have an acetabular fracture, as putting forces on the hip will not be transmitted to the pelvis. So in these situations, you may need to, in this case, I've used an external fixator, apply 2 pins just above the acetabulum, use that to reduce the sacroiliac joint, and then place the sacroiliac screws inside. Once you're able to reduce the pelvis and have it makes the reduction of the acetabulum after that much easier. So take-home messages. Remember that the static X-rays may hide an instability in the pelvis. So if in doubt, do some examination under anesthesia of these injuries, because the dynamic stress views can help you and aid you with the proper diagnosis. And vertical shear fractures, anterior fixation can help neutralize some of the deforming forces and make the posterior fixation and reduction easier. In combined injury, start with the pelvic reduction first and then fix the acetabular fracture. Thank you very much. And I will leave it now to Dr. Jamal.
Well, the moderators would ask the questions.
Yeah, Dr. Wahid, this Dr. Kumar here. I do have some questions that were raised up during your talk. One of the questions is, do you do suprapubic catheterization in acute settings, or do you just do a simple CBD?
Well, if there is no signs of bladder injury, I will put a normal, when operating, I will just do if that's the question, if I understood it right, I will just do a regular urinary catheter. But if I do suspect that there is a bladder injury, then yes, I would go with a suprapubic catheter, of course.
Okay, in continuation of that, there's another question on this similar to this. Do you advocate diagnostic peritoneal aspiration? Invariably, this pelvic fractures, somehow or other is also involving the abdominal structures. Or do you rely on the fast scans in order to tell you if there is any involvement of the abdominal organs?
Yeah, because I do have the FAST, I do have the ultrasound in my hospital, so we rely on that. And the other thing that we do is that right now we do a what is called a trauma CT. This is something that we do routinely now for any trauma patient that comes through. So I would not go for any type of aspiration, but of course the situation may be different if you're working in a hospital where there is no facility for a FAST or a CT scan. But where I work, I do have the facility for both, so I would not opt for an aspiration of the 300.
I think that will only might be practical for places where they don't have the facilities. I guess I hope every place would be able to do this CT scan, so that will be good. And the next question would be, is there any indication for surgery in APC1?
Yeah, well, for ABC1, there is no randomized controlled trial to look at the outcome if you do surgery versus no surgery. In my practice, if the patient has a 2.5 centimeter diastasis, not more, and there's no evidence of any posterior injury, he doesn't have any back pain, I will give them the option. I will tell them, listen, you could go without surgery, and we will allow you to start mobilizing. And if the patient is happy with that, we will just mobilize him. If he elects to go for surgery, we will just do anterior plating. In general, if the displacement is less than 2.5 centimeters, I would be inclined more to non-surgical management.
Now, coming similar to that,
stop. We're running short of time. We'll go. Okay.
Maybe I will just add on this question probably the next time around when everybody is done. Okay. Thank you. Go ahead, Dr. Kumar.
Thank you, Dr. Wael. So our next presenter is Dr. Adelwisa Bilen. She's a consultant at the St. Luke's Institute of Orthopaedics and Sports Medicine, Manila, Philippines. And for those who have been attending the regular air courses, she's that young, energetic Pelvi Acetabular surgeon teaching in all those courses. So she will be speaking on the transverse fractures, anterior or posterior approach. Over to Adele.
Thank you for the kind introduction, Jamal. And I would like to thank you and Asia Pacific Trauma Society for the kind invitation to share with our younger colleagues. My task is to talk about transverse fractures, choosing between the anterior or the posterior approach. So I have nothing to disclose, no conflict of interest, and I would like to acknowledge AO Trauma Lecture Archives for help in this lecture. So our objective for today is to discuss decision points in the fixation of transverse fracture types, depending on the choice of approach, positioning, reduction techniques, and internal fixation techniques. So this is how a transverse fracture is illustrated. So you can have an infratectal, a juxtatectal, or an ischiopubic segment. But before you arrive at a decision whether to fix or not and how to fix it, there are key questions that we need to ask. Are you sure it is just a transverse fracture? Is there a posterior wall component in the obturator view? And is there a split between the two columns of the ischiopubic fragments? Because this will be pertaining to the different fracture patterns in a transverse fracture. So there can be a pure transverse, a transverse plus a posterior wall, or the T-type of fractures. So approaches for transverse acetabular fractures, we have a list here. You can do posterior, you can do anterior, or you can do extensile. The workhorse of which is the Coker-Langenbeck. So we will discuss that first. So positioning, the patient is in prone, depicted here. This position aids in the reduction of the ischiopubic segment. It improves the quadrilateral surface axis. It allows clamp placement through the greater sciatic notch and controls the position of the hip, and it minimizes the sciatic nerve stretch. So with this one, gravity helps in reducing the ischiopubic segment. So there's somewhat easier reduction. Reduction aids or your tools, for the position earlier, you saw there's a distal femoral traction. You can do distraction of the hip. You can put an ischial tuberosity shunt spin to control the reduction and especially rotation. You can use the angled jaw clamps through the greater sciatic notch. It's called the Weber or the Weber clamp. And you can use other instrumentation such as the Farabaugh clamp or small pelvic reduction clamps. It is usually part of the set. So in the model, this is how it can be applied intraoperatively. So you have a shunt screw in the ischial tuberosity. This is a Weber clamp fixing the columns, and this is another pelvic reduction clamp through the sciatic notch to control the anterior and posterior column. How do you place it? But it all boils down to good exposure, and you need to take care of the sciatic nerve so that you can apply the clamps properly. This is how you use, this is a Jung Bluth reduction clamp. You use cortical screws and then manipulate by moving the arms of the clamps. So another one is, so this is the difference between a Farabov clamp and a Jung Bluth clamp. So it's just a matter of how you put the screws and then how you want to manipulate the fracture segments. So this is how it looks like in a model when you have the clamp through the greater sciatic notch, and this is how it looks like intraoperatively. Once you have reduced, then you can proceed with the fixation using a 3.5 millimeter recon plate, fixing the transverse fracture. What about a transtectal transverse fracture? So still, you see the Coker-Langenbeck is still the approach for this. However, later on, you will see another approach. So this is mostly for an isolated injury, and if treated early, this is the choice of how to do transtectal approach. What about the transverse plus posterior wall fracture? The transverse first has to be addressed, and then the posterior wall. The Coker-Langenbeck is still the most commonly used. However, the choice to do other approaches, you can do extended iliofemoral approach for a transtectal transverse fracture line if there are associated symphysis injuries or contralateral rami fractures, or there is extended posterior wall. And you may do also a Coker-Langenbeck with greater trochanteric osteotomy. So this is how it can be done. So you can approach it posteriorly, use the chance pin in the ischial tuberosity to control rotation, and then use application of the clamps. And then you can proceed with the fixation of the fracture. It can also be used for irreducible hip dislocation. So the Coker-Langenbeck can also be used for an irreducible hip dislocation. So once it is reduced, you can, with this approach, you can look at the intra-articular fragments. You can look at the sciatic nerve. You can look at any incarcerated chondral fragments. Check if there's a posterior wall, and this area is where the transverse fracture is. And then once reduced, you can proceed with fixation. So basically, the method of fixation is like any other fracture fixation, but more important will be the how we approach and reduce it. So this one is a modification of the approaches. So the injury, 62-year-old male with a motorcycle accident. These are the lines on the radiograph pertaining to the patient's injuries. There is also a sacral fracture. The SI joints are intact. So this is how it looks like in the inlet and outlet views. And then you see the transverse fracture at the area, at the coronal cuts, and then you see the comminution in the eggshell cuts. So it's quite difficult. This is a modification of the position, but still a Coker-Langenbeck approach. So it was a semi-prone surgeon's preference. And then this is how it was approached. So you visualize the sciatic nerve. These are some of the pieces of the posterior wall. So there was a lug screw fixation and then putting a spring plate and then proceeding with the reduction and the contour plate placement and contouring and then the plate fixation. And then we turned the patient and then proceeded to reduce because there are associated injuries. Aside from the transverse fracture, there is a symphysis pubis injury. So the position is supine, the approach is a fan and steel or the modified stapa. The first window for the ilioinguinal was prepared, but we didn't have to use it because the fixation was already stable. So these are the reduction and fixation pictures. What about the extended iliofemoral or the part of the anterior approach? When do we use it for a transverse type of fracture? So it's mostly for delayed fixation, transtectal, and if there are associated injuries. It is quite an extensile approach, but it is one of the approaches that can control both columns. So this is how you place the reduction clamps. You have simultaneous control of the column and there is intra-articular visualization. So you can put the clamps through the sciatic notch as well and through the anterior portion. So an example of a case done using the anterior approach. Another anterior approach, the ilioinguinal approach, it's a classic approach usually used if there are also other injuries that need to be taken care of. For this patient, it is a femoral neck and a femoral shaft fracture, aside from the transverse type of fracture and then the contralateral pubic fractures. So fixation, first fix the extremity so that you have better control in terms of traction, so that it aids in reduction of the transverse fracture. In the decision to use the ilioinguinal approach, one of the major factor will be the direction of the displacement and the rotation of the fragment. So if it's rotated and displaced anteriorly, then it's better to control the segments through the ilioinguinal approach. Factors complicating transverse fracture reduction, transtectal fracture pattern, because the forces acting on the fragments are great. Separate osteochondral articular dome fragment. If there are associated injuries such as the ipsilateral SI joint injury and symphysis injury or contralateral anterior ring injuries, and also if these fractures are delayed in terms of fixation. What about for the T-type fracture? Transverse fracture patterns associated with a vertical split that separates the ischiopubic component into two parts. There is a concomitant fracture of the inferior pubic ramus, and it is described according to the transverse and vertical component. So there are several, we all know that these are ligaments and muscles are attached to this, contributing to the displacement. So a key surgical point is the lack of control of the other column from one surgical approach, except for the extended iliofemoral approach. So the key question prior to arriving at the decision on what approach to use will be the displacement and location of the posterior column, the displacement and location of the anterior column, and the age of the patient. So key points in terms of decision making is, do you reduce the anterior column first prior to the posterior column, or do you reduce the posterior column first before the anterior column, and creation of an intact isquiopubic segment followed by reduction to the iliac segment. So we all know these are difficult fractures, the goal of which is to achieve a near anatomic reduction, 1 to 2 millimeter step off, through a single approach or preferably a non-extensile approach. However, the choice of incision is based on the location of the transverse fracture, the amount of displacement and location of each column, and other associated injuries in the pelvis. So for T-shaped fractures, still the most common approach will be the Cocker-Langenbeck. However, for the iliofemoral approach, you can still use transtectal transverse component, symphysis dislocation, still the same parameters, and if there is a wide separation of the vertical stem. We can also use the two approaches, whether planned or unplanned, and a Cocker-Langenbeck with a trochanteric osteotomy. So the difficulty lies in the limited access to reduce the other column from one surgical approach, except, as I have said earlier, the extended iliofemoral approach. So most commonly, the Cocker-Langenbeck, more than half of the cases, the Cocker-Langenbeck is enough. 16% might need ilioinguinal, and 16% uses two approaches instead of using the extensile approach. So this is how to first reduce the T segment. So the isquiopubic segment must first be reduced, and then it has to be reduced to the ischial segment. So remember that fixation of one column can block reduction of the next. So proper pre-op planning, especially for screw placement, is very vital to the fixation, reduction, and fixation of this type of fracture. So as a take-home message, the transverse group of fractures have different choices of approach, whether anterior, the ilioinguinal or the extended iliofemoral, or posterior, the Cocker-Langenbeck, and probably sequential using two approaches. The choice of approach by location of the fracture lines and displacement of each column and the presence of other injuries in the pelvic ring are the main factors. The reduction techniques and clamp placement have been well described, but it's important to note that it must be individualized for each fracture. Also important to note is that these are all difficult fractures, and the one who is assisting you is as important as knowing how to approach it. So sometimes two Pelvi Acetabular surgeons helping each other will make the job easier for the team and for the patient. Thank you very much.
Thank you, Adele. Now the talk is open to questions. I think Nicola will take care of that.
Yes, thanks very much. A great talk. I agree. Having another surgeon who's familiar with pelvis surgery certainly makes life a lot less stressful. A few questions through on the chat line here. How do you manage the impaction in the femoral head associated with an acetabular fracture?
Well, normally I don't have a lot of cases that have these impaction fractures, but so if you have, you need to have you need to lift it up and graft if the space, if the subchondral area will collapse. But mostly, so far for my patients, we're quite blessed that most of them are just chondral injuries but not impaction.
Right. And do you advocate the use of quadrilateral surface plates?
I do, but it's not available in the Philippines.
Okay.
But I've had the opportunity to use it when I was training in Germany, but it's not yet. We've been trying to have it available in the Philippines, but so far not yet.
Oh.
I would want to.
Yes, I feel very lucky. And what are your indications for using the Coker-Langenbach with a digastric osteotomy in transverse acetabular fracture fixation?
Mostly if I only do it if I have a concomitant femoral head fracture. Otherwise, I rarely do it for just a transverse fracture. If there's a concomitant head fracture that needs to be fixed, then that's the approach that is recommended.
And one last question, if we have time. Your choice of approach in a transverse fracture where the symphyseal hinge is also disrupted.
Transverse fracture with the symphysis.
Yep.
Well, I have. It's not in the recommendation because it's a newer approach. It's the STAPA, modified anterior intrapelvic approach. But if prior to the STAPA, the approach is ilioinguinal. That's what's on literature. But nowadays, I'm quite afraid of window 2. So I use the modified anterior intrapelvic with window 1 of the ilioinguinal approach.
Yes, I agree. I also like the STAPA.
Yes.
Right.
Nicola, can I get a comment, please?
Yes.
Yeah. According to the impacted fragment, I prefer the modified approach. So you can see the fractural gap, and you can pass the corpse elevator or something like that, and you can reduce the impacted fragment, and then you push the lifting screw so you can fix and maintaining the impacted fragment into anatomical position. I prefer the modified approach. That is the advantage.
Absolutely.
What we have done in some of these cases is that we have taken a piece from the non-articular area, which is non-negotiating area, the articular surface, and packed up in that space, which is created by the indentation, which cannot be corrected, fixed it over there, and then we have got the outcome, which is acceptable. But the defect, if it is exactly at the top, if it is lying on the side of it, many times we have observed them for many years, they don't really have much of the implications. It is only the weight-bearing area defects which are likely to be important to be taken care of.
Yes, correct. I agree.
Thank you, Adele, for a wonderful talk. Now that brings me to the
pleasure is mine.
That brings me to the third presentation. That will be on both column injuries. When do you need to do a posterior approach? And this presentation will be done by Dr. Vajara, who is the chair of AO Trauma Asia Pacific Education Commission and a consultant orthopedic surgeon in Bangkok International Hospital, Bangkok, Thailand. Over to Dr. Vajara.
Thank you very much, Jamal. It is very nice to have opportunity to join this interesting meeting and meet friends and also experts. I have learned the first 2 lectures and hope to learn another few lectures after this. When you asked me to talk about the associated both columns fracture, when do you need posterior approach? Maybe I would like to just introduce, let's say, start with this. What is the associated both column fracture? Actually, this is the blue is the anterior column, the red is the posterior column. So the dissociation, what we are talking about is the associated both column, which means the anterior and posterior columns are disassociation, and there is no articular continuity with the intact ilium or axial cyclotron. So we can say this is complete articular or floating acetabulum. Somebody talked that it is a very, very high level fracture of T-type fracture. Okay, there are some varieties. The first one you can see if you look from outside, outer cortex, the anterior column fracture line is just posterior to the ASIS, maybe from here, but it's just behind or posterior to. And the fracture extends into the sciatic notch, and vertical limb is going here to fracture the inferior ramus. So it's separate the anterior and posterior. So this is a high level So there is no contact between articular surface and exoskeleton. This is one varieties, which is very common that we see. And the next is, maybe you can see some fragments, not only one fragment of the anterior column, is maybe two fragments, some triangular fragments here. And if you look inside the pelvis, it is the same, that you can have this vertical fracture line through the acetabulum into the inferior ramus. And this is another varieties that it is a low varieties. You see the fracture line, instead of going into the crest, it is just below, very close to AIIS, maybe between AIS and ASIS, or even lower. But involvement is the anterior column into the sciatic notch, and this is a posterior column part, and this is not what it looks from inside. A little bit more difficult. And I think that the approach may be important. That's because stopper approach and lateral window, sometimes it is difficult to reduce this very low fracture. I may prefer ilo and guano in this case. And the other varieties is the other problems of it involved into the SI joint. You see there is an extension of the fracture line into the SI joint, because we can say this is fracture dislocation. So this is a varieties. So when we operate this both columns fracture, I think we have to see all the fracture lines, and it's a must that CT scan will be very helpful, not only the plain X-ray. The natural mechanism of injury, I can say most of the case is the posterior column is pushed medially, and the anterior column is pushed cranially and medially. So it is pushing from the lateral force. Lateral force is pushing everything into the pelvis and break it. And the point of breaking is just above the joint. And this is very common that Latino talk about the spur sign. You know, it is the intact ilium. This is the intact ilium, and then this is a displaced one in obturator oblique view. I think I have problem in finding spur sign in my series. This is another to show this is a spur sign, which means the intact ilium of both column, and this is a spur sign. Why we have difficulty? Because people send the X-ray in AP pelvis, and then they just jump to CT scan nowadays. So I have not a very beautiful spur sign nowadays. Okay. This is a principle of acetabular fractures, I think, for every type of acetabular fractures, because it is unlike other intra-articular fractures about the opportunity of treatment, because you have less opportunity to see the articular surface. Most of the time, you have to reduce our bony cortex as jigsaw puzzle, right? You have to make it like jigsaw puzzle. At that time, you cannot see the articular surface, except you have some, like Mary said, that transector, transverse, or fracture head that you go for trochanteric flip, and then you can see the joint. And then when you don't see the joint, you have to rely on the anatomical curve, concavity, the jigsaw line, and hope that the unseen articular surface will be reduced as well. And even though sometimes it looks very nice, but on the opposite side, which is articular surface, it may not be that so. So we have to make best out of the selected approaches to see the fracture very clear, to have opportunity to reduce directly that cortex, right? So we can say most of the time, the both column associated both columns fracture, we can say they prefer anterior approach, even ilo and guano, or as we talk about modified stopper plus lateral window. I can say this is very nice in most of the case. This is a case number one. I have about 7 cases. I try to be in time. So you see, this is the medial displacement of the posterior column and upward displacement of the head and medial a little bit. And this is breaking of the ilo-ischial and ilo-pectineal line. It is obturator view. And this is CT scan. I will spend some time for you to see the 3D CT scan on the left corner. And this is very most common that we can see this both column fracture. The fracture line is extended high here. And then this is a breaking of the low fracture line. And this is the fracture of the posterior column displaced medially. I will rotate this to let you see one of the common fragments. This is one of the superior dome kind of triangle. Very often we have this break. And if you look into the right picture, there is this kind of wedge or triangular fragment, which is part of the wall. So very common that we can see this. But in this case, you can see the displacement of the posterior wall is not that much. The displacement of the anterior is more and some comminution. So the decision is just straightforward. We reduce the fracture by distal and lateral traction to reduce the head back. And then we try to reduce the iliac crest, use this small buttress plate to buttress the high iliac fracture line, the anterior column fracture line, to reduce whole anterior column back. And then we bridge and make sure that the length of the pelvic ring is adequate or not long, not short. And then how, if it's possible, you can see in this iliac oblique view, to see the sighting knot, if we can reduce, because in this case, the displacement of the posterior, we can reduce it nicely. We can put 2 column screw. I think Dr. Takashi will talk about a percutaneous screw later on, about the technique. And in AP view, you can see it is in the ischium. And then that triangular fragment, it is the wall, part of the dome and posterior wall. If it's not displaced, you can do percutaneous fixation with this screw. So you can have this, in addition of the splinting of the ilium of the anterior column, we use LC2 screw very often nowadays. This is LC from the lateral aspect of AIS and then point to the PSIS, and this is a sciatic notch. So you see, this is a contraction after we fix with anterior approach alone, ilo-inguinal approach, or whatever. If you can do in stop and lateral window, that is fine. Look in the second case. The second case is you can see this triangular fragment dome is displaced a lot. And the medial displacement, you see, this is the head. How much is displaced? About 2 inches into the pelvic cavity. So on this side is maybe close up, and you can see how displaced it is of the anterior and posterior column and also the posterior wall. And look at this anterior, okay, it is like both columns in general. And then on the back, when we turn this back, you can see this fragment is the dome, which is a weight-bearing dome. It is not really a posterior wall, but it involves the posterior wall. We can say this is part of the wall. Do we consider this as special? One approach will be enough or not? So if we do the same thing, anterior approach, pull it distally, laterally, reduce iliac crest, anterior column, pelvic ring, not shorten. And because this is fracture close to the pubic, so we cross the pubic symphysis. And then we try to close this fracture. It doesn't work. Okay, we try to reduce the posterior column. You can notice that it is not perfect reduction of the posterior column here, you see. This is the curve of the sciatic, and this is a posterior column. It has to be here. But if it is not perfect like this, and you fix this posterior column screw, and then you hope that this screw will be automatically reduced with this not very, very accurate reduction of the posterior column. It is difficult. You can plan before that this may be not easy in anterior approach, and if we can end up with look like nice, but it is not nice because the dome is not congruent with the head. So in this case, it's not a good example. It is a not good example because you see the posterior column is not well reduced, and then just proceed, and we cannot reduce this anyway. So people talking about associated both columns fracture, some case will need 2 approaches. We can say simultaneous approach, which means you have to go for lateral decubitous like this paper of Harris. So you can see this anterior approach, even ilo-fibro, ilo-inguinal, and this is Coker-Lenkenbeck approach, separate approach. Or people do like a sequential anterior supine and then close and do prone position for the posterior. So it depends on your choice, but I think we have to plan before. This is the like Harris shows that he used separate simultaneous approach in lateral position, and this is the access that you can do in ilofemoral approach. And he keep the lateral cortex, not to strip the muscle of abductor out of it, but separate the cochlear approach to address the posterior. So in many papers, we can say that, let's say Lateral, Mata, or even Keith Mayo, about 1% of all acetabular fracture that needs two approaches, not only both column, is about 4%. It may be even more in our series. Depends on depends on the series. So just think about these two approaches and think before you go into the operating room will be better. Otherwise, you will fight against the reduction and you cannot do it and you spend 2 or 3 hours. And this is for a third example that you see one of the thing that you have to consider to go for posterior two approaches, because not only this can reduce the dome, but you have segmental fracture of the wall, which may interfere with the stability, and also you cannot reduce perfectly by front. So this comminuted posterior wall, I think we have to plan ahead with these two cases. On the first case I showed you is unreduced dome, and this is a segmental comminuted of the wall. I think this both of these cases you have to plan that we can go from the front first, and then you fix the crest, you fix the anterior column, even. And you have to make sure that you not fix and obstruct the posterior column reduction. And you have to put the screw here, LC screw, and then you turn prone to fix the posterior column screw, posterior wall. Now we go for case number 4. This is one of the varieties that we talk about both columns that I show the picture to you. This is fracture dislocation of the SI joint, the inferior SI joint. How can you reduce this inferior SI joint? If you look from the front, from the entry approach on the left photo, this sciatic buttress move backward. You see SI joint. I think it is difficult for you to pull it anteriorward to fix with the plate screw anteriorly. So in this case, the recommendation is to go prone and fix like a crescent fracture. So you just start from prone because this is the main fragment. And you cannot achieve, if you cannot achieve this fragment reduction, I think it's obstruct everything in the anterior. So just go prone and fix this and use this opportunity to fix the posterior column, which is every one of you can do very easy for posterior column, right? And then we turn supine and straightforward for anterior approach and fix the anterior column. So you have crowded of the screw here. The medial wall we may not reduce so well, but I think the weight-bearing dome, it is congruent, and that is good enough in this case. So because of this fracture, dislocation of the SI joint, you need to go from the posterior in this case. The fifth example, this is very comminuted fracture. Even the dome, I don't think this case even we fix it so well with this comminuted of the weight-bearing area. The cartilage is damaged a lot. But anyway, the only way that to have opportunity to have a good or better result is just to reconstruct it. The anterior column, part of the anterior column is not that bad comminuted, but the posterior wall, you see, this is displaced and very low. So I think in this case, again, if you look carefully, you have to consider posterior approach, whatever first, anterior first or posterior first, is depend on what reduction that you can do better at first. So because this case has a cross, the fracture on the other side, so we can do anterior approach with this long smiling plate. Again, crest screw, LC2 screw, and this is a buttress plate to push the anterior column back in place at the beginning. And this is a posterior column wall fracture, wall fixation. So case number 6. I think you all agree, if you see this case, you will agree that with this severe displacement, the patient, I don't know how fortunately she survived, but how many weeks after the injury that we can operate. Not only the fracture displacement, but it shows that there is a severe bleeding or severe injury. So we have time to reduce it, but it is 3 weeks, 4 weeks after that. So it is for sure this displacement you have to go to plan for 2 approaches. And in my experience, I prefer to be separate, supine first, and then in this case, and then later on we can do prone position. I will show you this from the front. Posterior, you can see in this case, on the left photo, you see the posterior wall is comminuted. Not only the posterior wall which is comminuted, not only the display, but the sciatic notch is segmented fracture. How can you reduce from the front without going to the back and reduce everything? It is impossible, right? So in this case, we have to go for 2 approaches, not simultaneously. Somebody may talk about simultaneously, but I in my experience, I do separate by supine and then prone in this case. So we have to reconstruct the anterior column and then go back to reduce a segmental fracture of the sciatic notch and the posterior wall. So the last case, this is interesting case that seems like this is okay. Both column fracture. Yes, displacement is a lot. You can see this is very severe displaced. Even the head is still here, but the wall is there. But why the wall is not moving back a little bit? However, you see this, which is interesting for me, that the fracture of the posterior column here, you see, is normally I see the spiral fracture of this part of the stable part, and then we can reduce it well because it's kind of not transverse fracture. And you imagine if this is transverse fracture of this column that you have to reduce indirectly. It is impossible from the anterior. So you see on the right side, if you look from inside the pelvis, like from the stop approach, you see this is a fracture of the posterior column, and this is the fracture of the posterior column from look from behind. And this should be here. This whole fragment should be back here. And imagine the fracture femur transverse fracture, how difficult that you can manipulate a transverse fracture when you're plating in the past. It's got a lot of force to do so. And this is in C-arm image. You see, this is the blue and this is the red, is the posterior column. The blue is the anterior part. And you see we try to reduce it as usual. We go into the anterior first. I don't know that this may be a wrong decision, but we decide to go from the anterior first as usual, and then we buttress this anterior column, put in the screw of the iliac crest, and then ILC2 screw to splint to make this multiple fracture into simple fracture. It seems like the anterior column reduced well, but you cannot reduce the posterior column back from the front. Even in the stopper approach, I try to push very hard, try hours. And this is very, very difficult. And look again, you see that this transverse fracture part is very inside the pelvis. It's locked there. So if I see again in this kind of case and transverse fracture, unlike the fracture in general, I will go ahead for the posterior first. And then we finish the anterior buttress part to push the anterior part of the posterior column with this subpectineal plate and close the wound and go for anterior to the posterior approach. And you see, it is not even easy for me to reduce that transverse fracture back of the posterior column. So I use 2 far above to reduce and then plating later on, which fortunately everything went well. And this is very crowded plates. But okay, seems like the bad fracture returned to its normal anatomy. So I will come to the end of the lecture. Take-home message is in associated both column fractures. Mostly anterior approaches, whatever ilo-inguinal or stopper with lateral window are sufficient. But when do we need posterior approach? When there is a displacement of the wall, which is significant instability, and you have comminution of the posterior wall, which cannot access by the anterior, and comminution or segmental fracture of the posterior column, like you see the comminution of the sciatic notch, lock or unreduced posterior column. And last but not least, in case that you go for anterior in general case and you have unacceptable reduction from the front, please do not hesitate to just turn the patient prone and do it. Thank you for your attention.
It's now open to questions. Kim, you're silent. Kim, you're silent.
Thanks for your wonderful lecture, Dr. Vajara. Yeah, we have some questions from chatting box. The first one is do you advocate using 3D printing for better pre-evaluation and planning? Have you experienced?
Okay, that is a very good question for this new technology. Normally, I think 3D printing, sometimes we need it for contouring the anatomical plate by normal regular reconstruction plate or pelvic plate. And we use this to contour. We flip the normal side to be on the fracture side and print it, and then we contour it. And then we mark that, okay, this hole has to be here intraoperatively, and that has to be there. And it's interesting that when we just do reduction, and then we put some gross reduction, and then you put the screw in. If it is well planned that this position is what you plan, it reduces the fracture nicely. And my colleagues already done many cases with the university as well. We talk together, and then they do kind of jig, like a targeting device of that plate, and then just drill for the direction of the screw and use that plate, contour plate, maybe printed from the 3D printing titanium plate. And then everything is reduced automatically. So this is one technology, but in real life, in everyday use, I think just contouring the plate from the plastic bone that we have still be a very good solution instead of custom-made printing. But this is a good idea. I think if you have facility to do so very fast in 1 day, 2 days.
Yes, thank you. I have also experienced the 3D printing. The mirroring image of the opposite side is very helpful to prevent the bending. It's very helpful, but not mandatory. Yeah. So next question is, what is your sequence of fixation when you use iliopubic screws to stabilize the AC components of the transverse fracture along with the PC plate?
One more time, please. One more time question, please.
What is your sequence of fixation when you use the iliopubic screws to stabilize the AP component, anterior column components?
Yes.
In transverse pattern. Yeah.
I think you talk about both columns of transverse fracture. Transverse fracture, right? Transverse fracture, if you flip from a prone position, I will clamp and reduce with that meta angle clamp, and use the finger to touch that this is already good in the anterior column, and then just go ahead with the anterior grade Ramesh screw first. And then you reduce whole column and hold it with that. And then we start with posterior plating, wall or supplement with the plate with the column. So the screw is first after reduction.
Okay, thank you. And next question is, how low is your threshold for using two approaches rather than one for the post-column fractures? That is your indication of two approaches? You already showed your cases.
Yeah, you means how what? The question
how low of threshold? When is your acceptable range of the only for one approach?
How long? How? You mean the operation that's
Yeah.
How long? Sorry,
How low?
I mean,
how low is your threshold?
How often do you have to change it from one approach?
Yeah.
How often?
Yeah.
Okay. Can I say change? We have to evaluate first that this will be planned, that we go from front simultaneously, not simultaneously, I mean sequentially. I think we planned before, but I cannot count how many let's say I have the during collecting of the number of the acetabulum cases, and then I may not check the number yet, but maybe in 1 year or 2 or 3 times that we can do these 2 approaches. Let's say not very often. Mostly both columns I can do it. I think it depends on the case. Acetabular fracture depends on the season as well. And then we cannot count the number. I have to go back and check the number first and then to come back with how many % of both columns, because people talk about acetabular fracture, which needs 2 approaches, but only both columns I have to check. And the other thing is, I think the number may be not important as long as you have to look into the CT scan and decide first that you go straight forward. Otherwise, you are in the operating room and then you have no reduction of the posterior, and then you have to spend 1 hour, 2 hours and decide and then change to posterior. So this take time in the operating. Just go ahead straight forward to the posterior by decision making fast. Maybe better to shorten the period of operation.
When you use the 2 approach, do you simultaneously or the stage the operation?
Sequential. I will not use simultaneously. Maybe only one case that not involve the anterior column. Actually, very displaced. No anterior column displayed that much, so I can go lateral window in semi-supine, and then I turn to the Coker-Legenbeck approach to fix the posterior column and wall. I have one case that do this kind of like a flip-flop. Just only one. Otherwise, I go sequentially. Yeah. And can you summarize the posterior wall fragment in post-column fractures? I experienced usually the articular side, the displacement is minimal, and the divergent, the iliac ring side, the displacement is more displaced. So you reduce the fragment with clamp and fix it. One is the indication of the reduce and fix the posterior wall fragment. I mean, displacement is when displacement is minimal. Will you fix it or leave it? See, if the fragment is big enough, and then minimal displacement, I have tendency to do percutaneous fixation when I go for anterior approach. If you mean that dome and which involve the wall, right? So I do percutaneously. So I prepare the cannulated screw, which is more convenient. But if it is big, like I showed the case number 2, it displays, I cannot reduce. I think we have to go ahead decision for posterior approach after we fix the anterior. Don't just leave it like that and fix it like non-anatomical.
Okay, this is the last question. Your case 2, number 2, the second case with the unreduced dome fragment, is it good to use a modified iliofemoral or a stopper with lateral window?
Unreduced, I think go for the posterior approach. I will not, if you just go ahead with lateral dissection of the abductor, the whole abductor, to reduce that fragment, I think it's just too much of investment of the blood supply of the bone, especially in very old patient and infection, bleeding. So I will just decide, close the wound, go to the posterior, and then this fragment normally it is posterior, a little bit superior, but you have opportunity to dissect and reduce it directly, and it's more accurate. And the point is, if it is very high, like superior dome, just go ahead with trochanteric flip. Trochanteric flip lost nothing much. I think it's relaxed a lot and reduce HO theoretically, and you relax and you can do everything. So I just go ahead for posterior, not just strip it from the lateral ilium.
Thank you.
Thank you.
Later time. So we'll go on to the next lecture. Thanks, Vajara. The next presentation is by a young dynamic surgeon from Japan, Dr. Takashi Suzuki, who will be speaking on the percutaneous fixation and acetabular fractures. He's a consultant trauma and reconstructive surgeon at the Taiko University Hospital in Tokyo, Japan.
Wait a sec, please. Let me see. Okay, here you go. Okay, good day. Thank you very much for the opportunity to present our work here. In the next 20 minutes, I'm going to present you with some of our cases of acetabular fractures treated with minimally invasive surgery. I hope to be able to share with you the thoughts of screw fixation of acetabular fractures. Minimally invasive surgery for acetabular fracture is a relatively new procedure. Open reduction and internal fixation are the gold standard in displaced fractures. Non-displaced and minimally displaced fractures can be treated conservatively. Percutaneous screw fixation in acetabular fractures has been advocated in several papers. Percutaneous screw fixation could reduce surgical time, blood loss, and complications, including neurovascular injury, hydrotopic calcification, and surgical site infection. It could also allow a patient to get out of bed early. However, there is no strong evidence that percutaneous fixation of non-displaced fractures can improve pain and mobility. Recently, one author reported that minimally invasive surgical treatment of minimally displaced fractures doesn't improve pain, mobility, or quality of life compared to conservative treatment. The authors concluded that conservative treatment should always be considered when open reduction with internal fixation is not necessary. In my opinion, only a very small number of non-displaced and minimally displaced fractures will potentially unstable and will displace without traction. Because the acetabulum is reinforced by abundant soft tissues such as muscles, capsules, ligaments, and labrums. If no reduction is required for the acetabular fracture, probably no fixation is needed. Today, I'd like to talk two methods of minimally invasive surgery for acetabular fracture. One is purely percutaneous screw fixation with indirect reduction or no reduction. The other is limited open reduction and percutaneous screw fixation. In my talk, I show you three types of screw fixation: LC2 screw through acetabulum dorm, anterior column screw between iliac and pubic bone, and posterior column screw between iliac and ischial bone. Insertion of LC2 screw is relatively easy. The surgical technique to perform percutaneous screw fixation of the anterior and posterior columns is well documented in the literature. In displaced fractures, the indication for minimally invasive surgery is elderly patients who are not candidates for ORIF due to multiple comorbidities. Elderly patients seem better able to tolerate imperfect reduction than younger patients. Severely injured patients who are not feasible for invasive procedures are also indicated for minimally invasive surgery, but they usually require appropriate reduction. Percutaneous screw fixation in non-displaced and minimally displaced fractures is performed in polytrauma patients with weight-bearing restrictions in the contralateral lower extremity and in patients who are expected to mobilize early for other reasons. I believe minimally displaced acetabular fractures associated with displaced pelvic ring fractures are also suitable. Of course, screw fixation doesn't always mean minimally invasive surgery. What you see here is an 87-year-old female who sustained a right acetabular fracture after falling from a wheelchair. The patient was very infirm at the time of injury. I thought it was not a good idea to keep the patient bedridden for a long time. I usually perform open reduction through the lateral window and percutaneous screw fixation for this type of injury. What do you think of this case? This patient developed an ileus after admission. so it was difficult for me to perform typical open reduction and plate fixation. I performed open reduction through the lateral window and percutaneous screw fixation. From now on, I show you illustrative 5 cases treated with minimally invasive surgery. This is a 25-year-old male who sustained polytrauma by auto pedestrian accident. The patient was transferred to our trauma center in shock status. Initially, a shoulder aneurysm was found and angioembolization with gelatin sponge was performed. The day before the operation, planned enhanced CT was performed and the arteriovenous fistula was identified. Selective colon embolization of the superior gluteal artery was performed. How would you have gone with this case? The blinking purple area didn't involve the articular surface. We chose limited open reaction and percutaneous screw fixation for this patient because neurosurgeons strongly recommended us to avoid intraoperative bleeding and hypertension. Also, there was a concern regarding soft tissue status after complete embolization of the superior gluteal artery. Manual traction of his left lower extremity was performed. Small accessory windows were opened around the anterior superior iliac spine, pubic symphysis, and lateral buttock. As a result, estimated blood loss was about 130 milliliters. The reduction was not anatomic, but I thought it was acceptable. These are the X-rays taken 1 year after the operation. He was fully recovered, had no symptoms, and returned to his previous work. Here you see his outcome 5 years postoperatively. There is slight joint space narrowing on the affected side. Clinically, he has full function. What you see here is a 48-year-old male with insulin-dependent diabetes. The initial CT scan revealed combined injuries of the pelvis and the sternum. You can see a minimally displaced transverse acetabular fracture on his right side. We planned transsacral screw fixation for the sacral fracture and posterior column screw fixation for the acetabular fracture. Speaking of retrograde posterior column screw fixation, the supine position requires an assistant to flex the hip and bend the knee so that the surgeon may physically access the ischial tuberosity start point. Otherwise, there is not enough space to place the guide wire in the correct direction. The prone position for retrograde posterior column screw fixation can maintain the patient in a static position and facilitate reproducible fluoroscopic images. He was placed in a prone position on a radiolucent table. A small incision was made on the ischial tuberosity. After an appropriate start point was confirmed on both the AP and iliac oblique views, the wire was advanced carefully. Small fracture gap and translation could be reduced by tightening the partially threaded screw. These are the radiographs 1 year after the operation. Bone union was obtained with perfect reduction. These are the X-rays 4 years after the operation. No osteoarthritis changes are observed. This is a 72-year-old male with a displaced both column fracture with acceptable secondary congruence. The patient had used a wheelchair while going outside. He was also suffering from prostate cancer in the terminal stage. So I once decided to perform conservative treatment for this patient. However, it revealed that the patient also had a renal failure and needed to go to dialysis clinic 3 times a week and get on the bed. We performed inside fixation to improve pain control. Due to the displacement and a very narrow corridor in the posterior column, the screw insertion was technically difficult. And then the screws in the anterior column and supraacetabular region were inserted in a supine position. After the inside fixation, the rapid pain relief, transfer from bed to wheelchair, and early discharge from the hospital were particularly advantageous in this patient. 8 months after the operation, he complained no pain and could walk short distances with a cane. 10 months after the operation, he passed away from prostate cancer. Next case. A 23-year-old female fell from a height and sustained a sacral fracture as well as left acetabular fracture. She had suffered from a genetic disorder, osteoporosis, diabetes, and short stature were seen. At the initial hospital, external fixation for the pelvic ring injury was performed in addition to left femoral amnial fixation. She was transferred to our trauma center on post-injury day 11. We examined the pin size of the external fixator, and the infection by MRSA was confirmed. At first, we had thought open reaction and internal fixation of the acetabular and pelvic fractures as well as percutaneous screw fixation of the sacral fracture was desirable. So we removed the external fixator in order to prepare for skin incisions of internal fixation. The acetabular fracture was classified as both cold with a secondary congruence. Soon, she developed pulmonary embolism. She was intubated and on a ventilator, and she still needed for pulmonary care and postural change. For that reason, we decided to stabilize the pelvic ring injury and leave the acetabular fracture as it is. During the operation, I became afraid that the reduction of the pelvic fracture would result in loss of secondary congruence of the acetabular fracture. So, I put percutaneous screws around the acetabulum to maintain the position in place, and then I reduced and fixed the pelvic fracture with a plate. These are the postoperative radiographs where the congruence of the hip joint looks reasonably good. As you see here, plate removal was undertaken 2 years postoperatively. At this point, it appears that bone union was obtained, maintaining hip joint congruence. This is the last case. A 34-year-old male was involved in an auto-pedestrian accident. At the initial hospital, massive peritoneal bleeding as well as comminuted pelvic fracture was identified. Emergent laparotomy and packing were performed, followed by the intestinal resection and stoma formation. Due to persistent hemodynamic instability, he was transferred to our trauma center. Here you see the pelvis was so comminuted. On his right side, there was mainly a pelvic ring injury, and his left side showed an acetabular fracture. He was admitted in the ICU due to septic shock. Open abdomen management was performed. Fluid discharge continued even after the abdominal closure. The cultures were positive for some microorganisms. It took 16 days to recover from the septic shock. The fracture reduction was getting difficult. We decided this was too much time to wait in this fracture for this patient. So we performed closed reduction and percutaneous screw fixation while he still had a high-grade fever. This slide shows you the status 1 month after the operation. You can see several small incisions for screws and K-wires. If you look at this carefully, you notice that we don't have a very good reduction here. What you see here with the radiographs 1 year after the operation, the structure of the pelvic ring was recovered with bone union. 3 years have passed since the last operation. He has already returned to his previous work. Currently, his chief complaint is hip abductor muscle weakness on the right, which is probably due to gluteal necrosis following angioembolization. When you look at these carefully, you can see the X-rays show mild osteoarthritis of his left hip. In the future, total hip arthroplasty seems inevitable. I'd like to touch on the use of navigation before closing my talk. It has been reported that 3D CD navigation can provide better screw position and fewer malpositioned screws. So occasionally, we use 3D CD navigation. In addition, the screw trajectory can be planned more individually with 3D CD navigation systems. On the other hand, there is no neuroframing in the acetabular area. The sciatic nerve is a little far from the screw insertion point. Arteries are not so close except the greater sciatic notch. The only concerns are joint penetration and cortical perforation. One author reported that no significant differences in clinical complications were found between 3D CD navigated patients and those undergoing conventional fluoroscopy. The flexible guide wire could still be deflected during advancement, resulting in unexpected deviation between the planned and actual screw position. So the use of 3D CD navigation doesn't guarantee 100% correct screw placement. In other words, the navigation systems are not a substitute for the surgeon's thorough knowledge of the anatomy. The key to success lies in the thorough understanding of the radiography of the pelvis and the acetabular. Percutaneous procedures are difficult and not recommended for the surgeons with little experience in conventional acetabular fracture surgery. Thank you very much for your attention.
Open
Thanks
to
very much. Sorry. That was a great talk. Thanks a lot. A few questions from the panel. Do you use computer-assisted acetabular fixation, and do you find it beneficial?
Yes, occasionally we use 3D navigation systems, but I think it doesn't have 100% accuracy. And the important thing is feel and how the screw guide wire move during the operation. So I doesn't rely on the navigation systems completely.
Absolutely. Do you have an intraoperative CT scanner in your hospital?
Yes, but I don't use that. Because if there is some displacement, you have to perform the CT two times, 3 times, many times during the operation. It's not a good thing for the patient.
Absolutely. The next question is, when should we avoid EUA, I guess with the risk of potentially causing further injury, I think is what the question is asking.
EUA?
Examination under anesthesia, a stress of the...
Yeah, I know EUA. But for my patient, for the patient with several fractures treated percutaneous fixation, usually we don't perform EUA before the operation, because the displacement should be minimal if you want to put the screws percutaneously.
Yes. Yep. And What is the ideal patient for percutaneous fixation?
I think elderly patients is one of the candidates, but I'm not sure. I'm still not sure. Screw fixation in osteoporotic bone is sufficient enough to allow full weight bear immediately. So I'm still concerned about it.
And what is the size of the superior pubic ramus screw that you are routinely able to use in your patients?
In Japan, 6.5 millimeter screws is the only one. It has as long as 180 millimeters. So we usually use 6.5 millimeter screws.
Okay. Excellent. Thanks very much.
Mm-hmm. You're welcome.
Thank you. Now we come to our last talk, which will be by Dr. Ramesh, who's an internationally renowned authority on pelvic acetabular fixations. He's a member of the AO Trauma Expert Pelvic Group and the current president-elect of the Indian Orthopaedic Association. He will be speaking on acetabular fractures in the elderly, repair or replace.
Thank you, Jamal. The objectives are that we should be able to discuss the issues, what is different in elderly population, and what are the indications to keep them non-operative care, when to do a minimal invasive surgery, what Takashi has just right now talked about, when to go in for an open reduction and fixation, and when we should surrender and go for a primary arthroplasty directly. If you look at the literature, these cases are likely to be a situation of a high mortality. If you look at the figures, 33% died within a year. 84% of the deceased had a non-operative treatment, meaning by as the importance we give to the fracture neck femur, equally rather maybe more importance is to be given in elderly for the acetabulum fracture. Now, what are the issues? Problem is that in elderly, the bones are likely to be significantly osteoporotic, so the comminution is also more. These are the patients who are likely to have enough comorbidities. And on the other hand, just like in a fracture neck femur, we want them to be ambulating early to avoid the complication of being bedded. The kind of fractures are typical here because most often these injuries are likely to be fall on the side. So these patients either have anterior column fracture mostly, or anterior column posterior hemitransverse, or associated both column fractures. And if you look at the literature, what is published regarding this management of elderly, there is every option given from non-operative, percutaneous, late hip replacement to acute hip replacement, as well as internal fixation. Whatever the method is, one thing is clear that these patients must be mobilized early, maybe sitting to the chair, maybe getting out of the walker or crutches so that we can avoid the complications. Now, there is a situation when patient surgery is not at all possible due to the existing medical comorbidities. Maybe he is dementia, there is a significant soft tissue problems, dementia, and all those things, when it is not possible to operate upon. And for that now, because initially we were using Charlson Comorbidity Index, now it has been observed that if we use that combined comorbidity score, this is the best predictive for defining that kind of a case, which ideally we should not pick up for a surgery. The values more than 6 or 7 are likely to be indicative of taking that extra care of avoiding surgery in this age group. And what more is said, if you look at this paper, the critical analysis, which it says that these physiologically compromised elderly patients, even non-operative treatment is associated with as good a functional outcome as a healthier patient undergoing internal fixation. So when you weigh the risks along with the benefits, this is one situation where you should be taking care of avoiding the surgery. And then there are situations within those fractures when the articular surface is not displaced much. Now, what is there in elderly is that while in a younger patients, more than 2 millimeter step may not be accepted, in elderly, even 5 millimeter of the accept may give a good result. So the indications are accordingly little changed. Now we look to a situation when the surgery can be done. Yes. Now, in this kind of a situation, we must understand what the bone quality is. And this is one of the latest paper about that bone quality in elderly patients getting acetabulum fracture, which it as expectedly says that there is an abnormal structure, abnormal texture, because they are getting this fracture by low energy. And when you think of fixation of these fractures, we understand their cortex is likely to be very poor, their cancellous bone is likely to be too inadequate to give any fixation strength to the screws, and very high chances that our implants might come out. And when we are fixing them within the acetabular bone also, the inside bone is likely to be an empty area. So our fixations are not likely to be sufficient enough. Then we also know that most of these fractures, whenever they hit from the side, they fall on the ground, they have got a quadrilateral comminution. They might get a femur head damage. The cartilage might be worn out in this kind of a situation. And very important is the impaction which can happen in many of these patients in the medial, anterior medial side, posterior medial side. And this impaction is having of a poor outcome in all these cases. But again, our challenges are that we need to mobilize this patient at the earliest. And this challenge is further augmented if we understand that these are the patients who won't understand what is partial weight bearing. So it will be very difficult to ambulate them on a partial weight bearing protocol, because your fixation now needs to be that stable that does not affected by the amount of a weight bearing on the side. As Takashi just talked about, minimally displaced fractures, or we have the displaced fracture. As regarding minimally displaced fracture, surely there could be option, and the literature is enough to say that percutaneously fixation can be done. And all those kind of a fracture you can see over here, that if there is a fracture like minimally displaced fracture, and if you want to have an early ambulation, you can do from this place, pass over as an antegrade posterior column screw, or maybe you may be able to pass, as Takashi told, the retrograde posterior column screw, or you may be passing the retrograde anterior column or posterior column screws in this kind of a situation. So when the fractures are not displaced much. Now there is a very interesting study in the German pelvic injury registry. If you can see down over the graphs, in both the graphs, it has been seen that even if you do an open reduction or you do a close reduction with percutaneous fixation, you are able to achieve adequate amount of a reduction with close reduction or percutaneous techniques also. And this is all throughout the various fracture patterns. So wherever possible, one is able to get that reduction, I think percutaneous fixation is a better option. They further found it out, because if it is a close reduction, it will obviously have a less blood shot. It will obviously have a shorter OT time. It will definitely give to a hospital stay also. But Takashi was right in saying that if we compare with the conservative group, we don't really gain much. It is equivalent to a conservative group. Also, the benefit we get is that now this person is not lying on the bed and he's up and above. He can be ambulated at an earlier stage. We go for displaced fractures. Now, again, the issues include what is the surgical approach, what are the strategies in the reduction, strategies in stabilization, and what are the outcomes. We are very clear about the literature now, because this classical ilioinguinal is supposed to be more extensive an approach now. In elderly, it is clear that we should try to shift towards the modified Stoppa's approach in these cases, and it is a very well accepted statement now. We do use in some of these cases where we are able to get this reduction from the iliofemoral approach also, which we feel is very comfortable in this kind of a situation. As far as reduction is concerned, this one point, giving a traction through the greater trochanter is one of the main things which helps us in reduction, which probably, because we all know these are injuries caused by fall on the side, head has actually gone inside, and if we are able to reduce them out, we are likely to change the picture to us also. As Vajara was telling about the fractures, ABC fractures, my own perception is that when we are deciding about the surgical approach, we may be able to first get this reduction done and then reevaluate our patients by both all the views, and then we can make a decision that can help us in the decision making for the surgical approach also. Once we have gone into a Stopa's approach, obviously we need to push those fragments back, stabilize them over there. And the question is about the impacted dome. Stopa's approach is somehow very good in getting that impaction reduced also, because initially we used to go by a window through the alien vinyl approach. Now with the Stopa's approach, we can directly access to that fragment and we can directly reduce that. This is one of the latest paper we have got it, and what it says that whatever you achieve, you are not likely to achieve in their series anatomical reduction in elderly about 48%. And imperfect reduction is likely to be there in 40%. But the interesting thing is that whether it is anatomical or it is imperfect, the outcome is excellent to good. That is the specific thing about these elderly patients, that in spite of relatively not anatomical position also, the outcome is not bad. Now, how to stabilize them? Now, it's a very classical thing. Going from the medial side, you are putting a plate superiorly, or putting a plate medial. You can get all those kind of a fixation to hold it. Now, the question is, if you look at the plate designs, we have got many things which have come up in the patents. If you look at it, various kind of a quadrilateral stabilizing plates have been developed. But we all know that one from the main company is there, which as a the suprapectoral and infrapectoral designs have been taken most by this thing. But let's understand, the injury is something which is coming at an oblique level, and we are using these plates. So biomechanically, when you compare it, this is a latest study comparing that biomechanically, they have evaluated all these and they have just found one, that all are able to maintain the stability for partial or a full weight bearing activity. We are talking about elderlies. But suprapectoral brim plate, the 3 periarticle screws is the gold standard. So putting more emphasis on the medial side may not hold that well as the superior side is likely to have. We went further. I mean, we looked at the literature, or enough of literature, at least some guidelines we could make it up in the osteoporotic fractures, that a plate which is holding this area should not be used to bridge unstable region, should be able to have a good bone contact across the fracture, should be a load sharing, its fixation should be as close and as far as possible, and all screws must go to the cortical bone. And that is the concept with which we have started working on the implant for this osteoporotic bone. And our knowledge, basic knowledge, that this injury is not up vertically, this injury is not medially vertically, it's obliquely. Our plate must provide it oblique support rather than a superior down or a medial to lateral. And with that concept, we came out with our own design. This was the first design we came out with. Now we have got a lot of this thing. Now there are various points in this thing on which we have worked a lot on the anatomy of our own pelvic models in our own this thing. In our situations, we have worked on their anatomy, and then every curvature is according to some design. Then we tested it over the experimental lab also for the relative strength vis-a-vis classical plates, and we found it to be better in that kind of a quality. Now it can be has an option. It can be used full, it can be used half. Now this is half which I am using for a 72 years man from the iliofemoral approach only. Just a small approach, you slit inside, it holds that area because it buttresses that area. Once it buttresses that area, it with a smaller surgery, we are okay. But we do have the other design which go with the full Stopa's approach, and that way we are able to get buttress from medial side to lateral side. This is another patient where we have been able to buttress that area. It's primarily to provide us stability. Another area you can see it out that again we are buttressing it rightly from the medial side. Now the important thing is here we are not putting screws up down. We are not actually putting screw medially to laterally. We are putting screws from the brim toward the lateral side and inferior side. That's the basic difference which we tend to see it out. Again, here you can see it out, the same thing which I'm talking. In the Stopa's or the iliofemoral with the fennel steel approach, we are able to get this buttress after putting this LC2 corridor K-wire. And this is what I'm buttressing. Our screws are likely to hold in that direction, which gives us an option even to go bicortical also. Another situation also, 78 years man having this fracture with the kind of the stability we are able to provide with this kind of a situation. Even for the reconstruction of the dome also, we are able to get the dome down. Then we fix this plate. It buttresses every component of this comminution. And the good thing about this is that there is a bigger hole in the center which can be used as a screw also, with a bigger screw to actually purchase on the outer cortex. And this can give us a much better fixation. Now, this is another case with the same kind of impaction, the same kind of a stability. And if it's possible to see, this is a patient who was with us from Spain as a tourist, got this injury, we put up this plate. And after 14 weeks, he felt comfortable enough to send us a video of his ability to walk as well as possible. Now, we also understand the concept of a far cortical locking. That through the plate, we cross over, we purchase the other cortex, other side cortex, and it is supposed to give us a better fixation and better healing. So we devised in this very plate an option to put a fur locking screw in which we will pass a nut from inside, which will go to the outer cortex and stabilize it. And this is the kind of the concept that we put a plate inside. We have that far cortical concept over there, and this nut will take care of the supraacetabular area. Now we understand this is the poor quality bone. And if we are able to provide the inside this buttressing, and we are able to hold with the outside bone with the anterior pillar, the buttressing effect is best maintained in this kind of a situation. And you see 88 years man, we are able to make him to sit up post-operatively also with the kind of a fixation and the buttress effect. And again, here you can see whenever the quality of bone is poor, we are likely to go for this buttress effect in all these cases. This is all the concept with which we are able to have the early mobility. Now we analyze. Now this was the COVID time, so we called in last 2-3 years how many patients we have done elderly with this kind of a plate. If you can look at it, they were all fresh injuries. This Charlson comorbidity index we used was less than 3. It was 3, something like. Now, important thing is most of these patients were fixed were males. And many of them were caused by road traffic accident, not by this thing. And when we did this surgery, we did their EQ5 scoring. At a follow-up, we could get 19 out of the 22 patients on telephonically, and this scoring was done. And reasonable them of had a good to fair outcome in this age group. Now, why this plate was behaving better was, our perception is because it is completely offloads that area where the comminution is there. It has got a multi-directional screwability. It can we do have that locking option also in a posterior column screw, and its supraacetabular bicortical purchase also gives us a very good effect in this kind of a situation, which we have published. Because before that, when we were using the conventional plates, in spite of a good reduction initially, it used to collapse subsequently, leading to a replacement subsequently. But it was standard there in 2014. This paper says 23% of our fixations will turn into replacement as such in our elderly population. There could be advantage of having that late THR because by that time the bone quality is very well maintained. But the surgery becomes challenging because it is scar tissue, heterotopic ossification is there, defects are there. So these are the issues. And then there could be a situation that we can operate them when we are expecting the outcome to be bad. Why not to fix them immediately and simultaneously do a replacement surgery? We can do part of the surgery in this kind of a situation, just like here. He was a 60-year man with the acetabulum fracture, with the neck fracture. So we did not have much of the issue to stabilize STM and to do a replacement. Another case, significant osteoporosis, and you can see the head indentation, the poor quality of the bone, the comminution. So we went with the iliophumeral approach, stabilized the brim over that area, went outside and did the replacement in the same go. Another situation when we had, it was about 3 weeks traction has been given by somewhere, then he was brought to us at that stage. We thought it's optimum to get him ambulatory at that stage. So we did immediately the fixation and did a replacement. It is the subsequent follow-up to make him ambulatory. Or this case where we found that she was reasonably morbid enough to go for a reconstruction at that stage. So we went for this cage kind of a concept. Holding the cage medially and laterally, we went for a replacement in the first go. We had, in the last 3 years, we had done about 10 cases where we have done a primary reconstruction this way. Now, the profile is here, the Charlson comorbidity index was around 4. Average age was not very different, but we had now equal number of females. And more of these patients had this injury from fall now. If you look at the fracture pattern, most of these cases were anterior column posterior hemitransverse or ABC kind of a fracture. As far as hip is concerned, we use dual mobility cup in most of these cases. And our EQ scoring was not bad. It was reasonably okay in all these cases. The literature is now describing special type kind of a cups also for the replacement in this kind of a surgery, which can give us a better because our aim is early mobilization. They say with this cup, early mobilization is possible. Then for the early surgery, it is advisable to use a canceller screw or a cemented if the bone quality is very poor, graft those defects, have a cup stability better, and to prevent the dislocation which is likely to be there due to weak musculature, a dual mobility cup if we are planning a replacement at that stage. As far as outcome is concerned, yes, there is a reasonable count of an outcome in these cases. There is a very good paper of 6 years follow-up in these cases that says that primary reinforcing ring or a jumbo acetabular cup with the autologous bone grafting is the optimum option for this kind of a age. Now we try to compare our patients with internal fixation to a THR. Very interesting thing you can notice that when we did a THR, the insufficiency fractures we did more often. We did more in females. Age was not a criteria. Yes, a slight difference in the Charlson comorbidity index was there. So whenever we have got a female patient, primarily with the insufficiency fracture and primarily with the higher morbidity, probably our option has to be the THR. And you see, we did not do a THR in a transverse in elderly, did not do in a post-wall where we did a primary reconstruction, but ACPTH, ABC and AC fractures were there where our option was more towards the THR as such. And as far as the outcome is concerned, I think we were not very different in the outcome using both of these options. Now, there is an interesting paper of 34 patients where they say, yes, there is an option of surgery which with THA directly doing is a Fiore operation, improved implant survival, good functional outcome as compared to ORIF. So a situation when we have got the femur, the kind of a profile which is osteoporotic, comminution, indentations are the cases where THA should be our first line of management. This is the conclusion that when we are deciding about a patient who is elderly, we look at its the functional ability and ability to tolerate the surgery. If he is able to tolerate surgery and we want him to be ambulatory, we do a fixation. If we are anticipating the time, we are anticipating the comminution, we are anticipating associated problems, we can go for reduction, fixation, and replacement. Only when things are likely to be bad, patient is not able to be taken up for surgery, we can go initially for a non-operative treatment, optimize the patient at some later stage, we may be able to go for an arthroplasty. Thank you.
Dr. Ramesh, I'll be forwarding you the questions from the audience. One of the questions here is a patient with a Brumback type 4 indentation and osteocartilaginous shear fracture, would you fix or replace?
Yeah, Brumback type 4 meaning by there is indentation of the femur head. And obviously, we are not expecting it to go for very long because this, depending on the amount of indentation, is likely. So these are an ideal case for going for arthroplasty in elderly patients, especially so.
Okay, thank you. The second question would be, can impaction grafting be a substitute for a cage in acetabular defects in which a THR is required?
Yes, that's very important because our problem in an acetabulum fracture is the instability. It is not the defect only. If it is a pure defect which is a contained and a stable defect, we can obviously pack it up. But if there is an instability associated with, we need to stabilize. We also do it that we stabilize the posterior column from outside once we are going through the lateral approach or the posterior approach, and we might pass a screw into the anterior column as an anterior column screw, and then we can directly go for filling of the graft with the impacted disc. But stability is the key on which we can do any replacement.
Okay, thank you so much. Now the final question. When do you advocate primary THR in the elderly?
Yes. So as I was concluding it also, that when the patient you are looking at has got the injury which is highly comminuted, the bone quality is very poor, the kind of a reconstruction is not likely to help him out, femur head is indented, the hip is already arthritic, or there is a fracture neck femur, are all those indications where, and there are comorbidities also which the patient may not be able to go for a subsequent again surgeries. It is better to go for a replacement in the first go.
Thank you very much, Dr. Ramesh. Back to you, Jamal.
There's actually one more question. Sain sir, when do we get to use AQP?
When do you want to use?
AQP.
Yeah. This we have labeled as anatomical quadrilateral plate. This actually, when we designed this plate, we had studied a lot of things around the curvatures in that area. So we designed it for every level, every kind of infection, every fracture pattern also, giving it an option because we studied a lot of literature on the osteoporotic sternum fractures. And so we devised it. Now that needs a kind of a very finalized thing. Now we are using it as a trial for last 4 years now. I'm just waiting for the enough outcome to be there with me. When we have all those cases followed up, I think we should be ready for the market also.
Thank you very much. And thank you to all the speakers for a lovely session, for your time. And the APOA and the Asia Pacific Trauma Society is utterly grateful for the time that you've given to our educational initiatives. And we will keep calling back on you for further educational initiatives. Thank you very much, everybody.
Thank you. Thank you, everyone.
Bye-bye.
Take care.
Bye.
Thank you.
Adele, thank you, Wael. Thank you, Nicole. Thank you. Bye.
Meenakshi ma'am, can I end the streaming?
Yeah, you can end.
Okay ma'am, bye-bye.
Bye.